both in terms of real practice and in terms of the guidelines that we have. What you find is that most of the time, if they have chest pain, which is believed to potentially be of cardiac origin, they get a CT scan done. And if that doesn't show obstructive coronary disease, then in too many cases, the process stops there. But what very rarely happens is that whether the question is asked, could this be one of the endotypes of angina where there is no obstructive coronary disease? So in other words, could this patient have microvascular disease? Could they have one of the other problems, such as a capillary rarefaction due to a cardiomyopathy, or indeed macro or microvascular spasm? Now, that's a great shame, because we know from research that in fact the percentage of people with chest pain who actually have obstructive coronary disease is now a minority. So the way that we are behaving actually means that the majority of our patients do not get managed. And that, frankly, is a bit of a scandal. What I would really hope courses like this will actually achieve in the future is that they will make us realize that angina is not the same as ischemia, is not the same as obstructive coronary disease. And that if we actually think about our patients as we should be doing, and that we actually aim to solve their problem, we'll actually start to think about, if this patient clinically has angina, what are the other possible causes? And then we might actually start to manage that properly.